Good morning, everyone, and thank you, Dr. Hawk, for the introduction and the invitation to speak today. Glad to see this great turnout. I'm going to be talking to you about surgical options for GERD, for reflux, and I have nothing to disclose. So you all know GERD, or gastroesophageal reflux disease. It is essentially the presence of sort of chronic, recurrent, troublesome symptoms or complications related to reflux of acid contents or gastric contents into the esophagus. And it's fairly prevalent. 20% of the population suffers from some degree of GERD. And the symptoms are, the classic typical heartburn, maybe regurgitation, and some less common symptoms like dysphagia or chest pain, chronic cough, and some of the laryngopharyngeal symptoms like voice changes and so on. In about 40 to 60% of patients with GERD, they'll have a hiatal hernia, and the hiatal hernia results in a disruption of the anti-reflux mechanisms, and the presence of a hiatal hernia and the size of the hiatal hernia does correlate with increased esophageal acid exposure. It correlates with more severe GERD and a more likelihood of complications like bad esophagitis or Barrett's and all that. And the hiatal hernia typically is the type 1 hiatal hernia, which is what we call sliding hiatal hernia, which is the most common type of hiatal hernia. Is when essentially the cardia and the GE junction is sort of herniating up into the mediastinum. That's sort of the sliding hiatal hernia type 1, which is the most common one associated with GERD. The other types of hiatal hernias, which are what we call paraesophageal hiatal hernias, they're sort of different pathology, and we're not going to address them today in my talk. So how do we manage GERD? Obviously, it's a very common disease, and we'll manage it medically, right? So these are managed with lifestyle modifications like weight loss, smoking cessation, of course, dietary changes, and PPIs is sort of the standard for patients, and it works really good. The heartburn responds pretty well to medical therapy. Regurgitation also improves with medical therapy, although it doesn't respond as well. The regurgitation is more likely to be a persistent symptoms despite PPIs, because regurgitation relates more to the amount of reflux, the volume of the reflux. Obviously, PPIs suppress acid, neutralize the reflux, but they don't stop it altogether. They do reduce the volume of gastric secretions, but it may not respond to, doesn't affect regurgitation as much sometimes. Chronic cough and LPR is also not as well controlled sometimes with PPIs, so somewhat limited and inconsistent response to PPIs. So when do we consider surgery? Well, patients come see us sometimes if they're not responding very well to PPIs, or they have a lot of breakthrough symptoms. That can be an indication to consider surgical management. We do see some patients come in to see us because they're worried about long-term PPIs outcomes or concerns. We know that PPIs are very, very safe. We always counsel patients that it's very safe, and the long-term issues are really not concerning, but some patients do get concerned about staying on them, and they want to get off them. Maybe they're concerned about the very slight increase in bone fractures, or maybe they read about some weak association with dementia, what have you. I don't think they're very valid concerns necessarily, but it is a common reason why people come and seek surgical therapy. Sometimes people have intolerance to the PPIs or side effects. They're usually very well tolerated, but occasionally you have patients who have symptoms, have nausea, have diarrhea or bloating or something like that, that basically they have to get off them. I mentioned regurgitation as sometimes being a symptom that does not always respond as well to PPIs, so that could be an indication. And larger hiatal hernias. A hiatal hernia more than 5 centimeters, usually we would sort of consider surgery. Again, with larger hiatal hernias, more significant symptoms, less response sometimes to therapy, and progression, potential for progression of that hernia to a larger paraesophageal hiatal hernia. So when we see a patient with GERD, it is really critical to do the proper workup when we're considering surgery. So obviously everybody typically comes and sees us and they've had an EGD already, and endoscopy is critical for these patients to make sure we have that. We want to assess for esophagitis, of course, Barrett's esophagus, any other mucosal pathology, but looking for hiatal hernia. So I think it's a must that they've had a recent endoscopy, and if they haven't had one, we will definitely refer them to have it done. We want to also make sure that we have objective diagnosis of GERD. We can't just rely on symptoms. So if they have bad esophagitis or even LA grade B or higher esophagitis on endoscopy or Barrett's, so that we have a diagnosis. But if not, we want to do a 24-hour pH study or a Bravo testing to see what's the esophageal acid exposures like. We're going to measure that objectively, and we're going to correlate that to their symptoms to make sure that the actual acid reflux is responsible for whatever symptoms they're experiencing, which allows us to really counsel them as far as expectations postoperatively. Upper GI study, we do often get that sometimes, especially if we're concerned about a larger hiatal hernia or to assess the anatomy a bit better. We do esophageal manometry on all these patients. You heard a great talk from Dr. Khan about what we do, what we do and what we look for, but that's really important to rule out any other esophageal motility disorders and to also tailor our surgical therapy. And I'll talk to you a little bit about how we sometimes decide on which surgery we're going to be doing. And occasionally, if we are concerned about gastroparesis, we will get a gastric emptying study. So all this is kind of what we are going to do first before we even consider surgical therapy. So what do we do with surgery? There are two components to a surgical treatment for GERD. The first one is going to be doing a hiatal hernia repair. Okay, I mentioned most patients have a hiatal hernia. We're going to basically bring the stomach out of the mediastinum, bring it back into the stomach. We're going to establish that intra-abdominal esophageal length. That's going to be very important to have. And then we're going to close the hiatus to kind of narrow down the esophageal hiatus to a normal size. That actually is about 80% of the efficacy of the surgery. That's going to be probably the biggest component in achieving that anti-reflux barrier. And then we're going to add an anti-reflux, Then we're going to add an anti-reflux procedure, and there's a number of them we're going to discuss, from fundoplication to CTIF, magnetic sphincter augmentation, bypass, and other therapies. We're going to go over them today. So first is sort of the Nissen fundoplication or the total fundoplication or 360-degree fundoplication. That's when we're using the stomach. This is a case of mine recently, small hiatal hernia. And basically, this is a completed dissection, so we have to basically reduce the hernia and create that esophageal length. And then we close the hiatus by approximating the right and left crus to kind of tighten up the esophagus. We usually have what we call a bougie, which is a tube inside the esophagus to allow us to calibrate how tight we make it, so we don't make it too tight and cause dysphagia and what have you. And this is kind of how the hiatal hernia is done. That's the first part of it. Then the fundoplication consists of using the actual fundus and wrapping it around the lower esophagus. You see we have a pretty nice and long intra-abdominal esophagus, and we're creating that full wrap of the fundus around the esophagus to create that, essentially the valve. And so it's done with 3 sutures, and the fundoplication is done somewhat loosely. We can see the hiatal hernia closure is not very tight, and this is a completed repair. So we have a lot of data on fundoplication, on Nissen fundoplication. It's not a new procedure. It's been around for a long time. We have a lot of studies out there, up to 20 years of outcomes. And we know it's a very good, very effective procedure. If you look at symptom relief of heartburn, regurgitation, 20-year data, 79 to 95% of patients experience symptom relief. We do get some people that get recurrence of some symptoms, either occasionally or more frequently, up to 20% at 20 years. And there is a certain degree of patients who might need another surgery. It could be from recurrent hiatal hernia or maybe recurrent reflux. Persistent dysphagia, however, is rare. To have dysphagia that goes on for a long time is rare. 2%, 3% maybe at 20 years, so it's not very common. Gas bloat syndrome is, however, not uncommon, and certainly we counsel patients about it. The valve that we create is pretty strong, and it basically prevents people from burping as easily, and so they get less burping, so more bloating, and they can get gas bloat in about 10 to 13% of patients. Not the majority, of course, but that is a concern that we try to address with patients preoperatively. Overall, patients who have a total fundoplication are very satisfied long-term, up to 90% satisfaction at 20 years. So very good operation. But sometimes we do something less. We do a partial fundoplication. So we're not taking the fundus and wrapping it around 360 degrees. We are doing a partial wrap, so we're going 270 degrees, what we call toupee fundoplication. You see that in that picture here. Or sometimes we do the same thing, but bring in the fundus from the front, doing an anterior partial fundoplication. So there are other options we would consider, and typically this partial fundoplication is definitely our preferred approach if somebody has an effective esophageal motility. So if the manometry shows that, we're going to probably favor a partial fundoplication. So we're not adding a very tight valve when somebody's esophagus is not working as strongly. Long-term results, interestingly, between the Nissen and the partial fundoplication are pretty good, pretty similar. As far as controlling GERD and improving quality of life, doing a partial and a complete, patients do pretty well regardless. So we do favor the partial if we have any concerns. Now, some studies say, well, maybe in the long term there's a modest increased risk of recurrent reflux with a partial fundoplication, so something to keep in mind. And especially for my younger patients who have a normal esophagus, I kind of consider that possibility and might offer them a complete fundoplication. But the advantage of that, certainly in the short term, is that patients have less issues with dysphagia, less issues with gas bloat, less issues with inability to burp or vomit and what have you. So early on, it's definitely patients feel better from that perspective. Now, long term, between a partial and a total fundoplication, not really a big difference. This is a very good study, prospective randomized trials from Sweden, over 300 patients randomized, and the results at 15 years, so really good long-term outcomes comparing a partial to a complete fundoplication, and specifically looking at dysphagia. They used a dysphagia score, with 1 being no dysphagia and 4 being at least 3 episodes of dysphagia a day, and we look at dysphagia for solids and liquids, no difference between the groups, and the average of score of 1.2, so pretty close to normal, essentially, and no difference between the two. So when we look at fundoplication and we're looking at which one to do, we again look at the manometry, and we will discuss the options with the patient, looking at all this data, and whatever the patient's preference, what their main concerns are, et cetera, we tailor the procedure to what the patient is most concerned about. Now, there is a TIF, which is a transoral incisional fundoplication. This is essentially a non-surgical option done endoscopically, where using that device endoscopically, you plicate the fundus, you suture the fundus onto the esophagus with full thickness sutures to create essentially a 2 to 3 centimeter valve or a sort of a 270-degree fundoplication endoscopically. It has limited indications. Typically, you want patients to have either no hiatal hernia or a very small one, less than 2 centimeters, and no other complicating factors. They're not obese, they don't have significant esophagitis or what have you. So that can be an option for some limited patients. However, the results with TIFs have not been great when we look at outcomes. Typically, 30 to 60% of patients in studies may get back on PPIs between 1 and 5 years. And when we look at normalizing their acid esophageal exposure, 29 to 72% based on the studies you look at. So not perfect, and about 17% of patients, of these patients, end up having a surgical fundoplication later. So the results are somewhat, they're not great, and the indications are somewhat limited. So the thought was, how can we improve or increase the efficacy and how many patients can qualify for it? This is the concept of CTIF, or concomitant TIF, which is essentially doing a laparoscopic hiatal hernia repair, like I showed you, and then stopping there and then doing the TIF at that time, at the time of the surgery. So combining the TIF with a laparoscopic hiatal hernia repair, and that is a procedure that you hear about, and you look at the data. Right now we have somewhat limited data, a shorter sort of follow-up. In this one study that published recently comparing a couple of anterior fundoplications to a CTIF, the outcomes at 12 months were similar. So patients did equally good if you did a toupee versus a TIF, along with a hiatal hernia repair. So at 12 months. So short, long-term results, but they're pretty good. The question for us, and why this is not a procedure we have adopted in our practice, is sort of if the results are equal, doing a TIF really adds cost because you're adding another device. It adds length to the procedure. And it's difficult to coordinate, the surgeon's time, the GI physician time, and all that. This creates a very more difficult situation. So I think it's a procedure or a device looking for an indication yet. Maybe over time things will change, but right now, I haven't adopted that in my practice. Magnetic sphincter augmentation is something we certainly offer. On the other hand, this is another procedure of mine here. This is a patient with a previous sleeve. It's basically a magnetic beads that they create a ring that you place around the lower esophagus, and then you close that ring together here. And basically with the ring like this in a closed position, it's going to stop the acid from refluxing into the esophagus. Obviously, we've done a hiatal hernia repair here as well. You can see the sutures there. However, when the patient eats, those beads will separate. The food will, when the esophageal motility will push the beads open, the food goes through, and then it closes. So it's a dynamic device. And this was FDA approved in 2012, so now we have really good long-term data. We have studies, up to 5 years of outcomes, and the patients have done really well. So we're kind of happy with the results we see with this, and we have adopted that procedure in our practice. We look at GERD, health-related quality of life scores, significant improvement up to 5 years, a score of average of 25 over 50 preoperatively, down to less than 5 postoperatively at 5 years, so really good outcomes there. And then PPI use is also significantly decreased from 100% to less than 20% at 5 years. And again, this is a study, again, at 5 years, looking at improvement in reflux and GERD, and really GERD, by the way, for regurgitation, very effective with those symptoms, and very good patient satisfaction. Briefly, I'll talk to other surgical therapies here. Gastric bypass, Roux-en-Y gastric bypass is a predominantly weight loss surgery. We all know about it. Dr. David will talk about it. But it does have a very good anti-reflux benefit. So it really works well as an anti-reflux procedure. So if somebody comes and sees me and they have a BMI over 35 or certainly over 40, I'm going to counsel them to have a gastric bypass. In the fundoplication, it's not going to work as well. They're going to have a higher failure rate, and the bypass will be a great operation to address their weight, but also their reflux. We also would consider a gastric bypass as a salvage procedure. If somebody's had multiple previous fundoplications and failures and all that, that could be a good salvage procedure regardless of BMI. And I will mention a sort of investigational procedure called Reflux Stop. It's a procedure that's currently being studied in the US, going through the FDA process. It's been around in Europe now for about 4 or 5 years with good outcomes. It's a procedure that involves putting a silicone implant in the fundus and suturing it in place. It basically restores the angle of His without necessarily going around the LES, without going around the esophagus. So we'll see. You might hear about this procedure in the future. So in conclusion, I think to have a successful anti-reflux surgery, of course, the surgery is important, and the different surgeries are important, but it is very, very critical to have meticulous patient selection and go through a thorough preoperative evaluation in a multidisciplinary fashion to make sure we do the right procedure for the right patient and set the right expectations. So thank you very much, and I'll take questions later.